like to introduce our next speaker. Just on that comment about the MIS-C, anecdotally, we have not, despite being 4 to 6 weeks post the peak, been seeing a lot of cases, I don't think. So that may be some, and I haven't seen any national statistics on that yet. So I think that will be something that we're going to see in the next little while as people are able to analyze and the groups that are looking at that start reporting on the second wave. Prof Wolfgang Preiser is a medical virologist, and he's the head of the division of virology in the Department of Pathology at Stellenbosch University here in Cape Town, and associated with Tygerberg Hospital. And he's going to be talking to us about an update on SARS CoV-2 testing in children. I think the lab is an unknown and mysterious place to many of us, but this pandemic has certainly forced us to work closely and collaboratively with them. And he will hopefully demystify some of this and take us into the lab and what some of their challenges and realities are, and help us to understand and interpret correctly the testing options in children. So over to you, Wolfgang.
Thank you very much, Andrew, for the kind words, and to all of you for hosting me and letting me speak, and also for your patience, because I know that we in the lab are oftentimes those that let you down with urgent results and so on. So I'm very cognizant of that. For those who are not from the Cape Town area, this is Tygerberg Hospital here in the back, and the top floor of the faculty building is where our lab is. It's part of the NHLS and does a lot of testing. I'll start with the obvious. The gold standard diagnostic test for COVID is still, of course, the detection of viral RNA in a respiratory tract sample, typically, ideally, nasopharyngeal swab. And then why I like to show this is just to illustrate that it's not that easy. In fact, it even leaves out some steps in between. It's quite a protracted a type of test. We can do this very efficiently using automated high throughput machines. But when we start with a swab sample, and then from that swab, we first need to elute it into a solution and get rid of the swab. And so that all adds complexity. It's not necessarily difficult things to do, but if you're facing hundreds and thousands of specimens, it becomes just a significant extra burden. Now, where are we in the time course of disease? This is symptom onset here, and the weeks down here along the x-axis, and this the y-axis basically shows the probability of detection. So PCR on a nasopharyngeal sample would be positive from approximately 2 days prior to symptom onset to, well, a while thereafter. That can be, in some cases, many weeks later, but is usually at least 1 or 2 weeks. Now, and I now jump forward for as serology only comes up later, but this also shows the antibody response. And basically what it clearly shows is, and of course, MIS-C patients are the big exception, is that antibody testing is not helpful in diagnosing acute suspected COVID. So this is commonly used, and you'll see variations on this graph later on. So basically, all we had to do is, to set up the assays that were developed very quickly. I think one also needs to acknowledge the things that worked out well during the pandemic. Yes, there were. For example, the virus was detected very quickly and sequenced, and assays were actually made publicly available even before the people who did that had access to the samples. So in theory, all should have been well as regards laboratories, but to then set it up, validate it, and then ramp it up from 0 to huge numbers is still a huge challenge. We then had these issues about what is the ideal sample type, how to ensure the quality of the sample. So all sorts of things have been tested and are still being tested. As I mentioned, the swab, in order to get to the PCR, needs extra preparation. That is an additional step for which there's no automation. So there is a lot of hands-on work with a potential biosafety hazard. And of course, the the opportunity to contaminate other samples. So it still needs to be done very carefully, and it takes significant time. And PCR as such is still quite a demanding laboratory technique that needs skilled staff and special equipment. On top of that, the world faced shortages of things that we never thought we could run out of. I mean, we all have had the experience of running out of alcoholic beverages in our own stores at home, but that the world would run short on ethanol, which is a component of most extraction kits for nucleic acid extraction. That is something I would not have foreseen. Likewise, running out of swabs or simple buffers is something unimaginable, and I have learned not to take anything for granted. Even simple things can run out. The more complicated reagents and consumables that one needs for many types of lab tests are and continue to be a problem. And that is something that's not unique to South Africa in our situation. That's actually been observed the world round. So this is a typical day, and this keeps refilling. So it's basically bottomless. We work through these samples that come over from reception, and by the time the technologies comes back, the table will be full again. And if that meets a shortage of consumables and reagents for what we had then in terms of extraction system, which is here the bioMérieux one, and you see even here the numbers of samples you can process at any given time is basically 3 times 8, so it's 24. Now look at this slide and you realize that you've got a lot of these machines running at the same time, and in order to run they need these very special plasticware here, which we still don't get enough of, and various buffers. So that is the problem. In theory, of course, everything can be resolved. There are high throughput assays. We actually have a lot of the equipment, the big machines that are used to run them through our antiviral rollout program. But to the present day, we can only get a fraction of the test kits that we would like to have. And the reason is there is just global competition for that, and these things are not easy to manufacture. At the other end of the spectrum, of course, a very good test, and it is an excellent test, is a PCR contained in a cartridge system like the Gene Expert. Again, South Africa and many other African countries have a wide footprint of these machines for TB diagnosis. So actually looks ideal, and a lot of people who could use them. Problem is these are still very sought after, and we get far too few for our needs. So all those things basically let us down, and we resorted, and I think overall the NHS has done a fair job. And I also take some consolation from seeing that our private colleagues in the private labs also struggled with the demand and the supply issues. So I think we are all in the same boat there. We really increased our capacity by mixing and matching. So acquiring a number of different systems, most of them open, that is able to use components supplied and test kits supplied from different manufacturers, and at the same time reasonably automating the process. That is not a fully automated thing. It still needs hands-on time by skilled operators, but it's not all manual. Now, I very much like the Western Cape dashboard because it shows these different metrics of the epidemic curves, and none of them is perfect. But if you take them together, they all make sense. So I think it becomes a very strong message, and this is just our part. That is what we contribute, and in fact, this is only part of what went into their dashboard, because this is only from our lab. So it's only basically 50% of the public sector patients in the Western Cape, and this is the percentage of positive. So this is the positivity rate. And when you get to these levels here, above 20%, and in some countries like Korea, they would not actually accept anything higher than 5%, because it basically means you are not testing enough. You are really selecting patients that are going to be tested, and it's exactly what we did at the height of the peaks at the time last year, but now again at the end of last year. And the criteria for qualifying for a test were made stricter to preserve laboratory capacity for those patients who need it most, which basically means automatically that we don't have a good idea of numbers. So we are missing cases out here. And this is why it's so precious to put these different sources of data together that in relation to one another convey a clear picture. Now, PCR remaining a problem, quick rapid PCRs by gene experts still being scarce and only available to a lucky few patients when there are kits available. What about rapid antigen tests? They detect the SARS CoV-2 nuclear protein. They are very fast. They can be used at point of care near patients. So somebody who can do a rapid HIV antibody test can also perform them. They are relatively inexpensive, a lot less than a PCR. They are less sensitive than nucleic acid testing, i.e. PCR, but would they still be able to identify most people who are infectious? And in fact, that is our observation in adults. What we found is that rapid antigen test positivity correlates quite well. Now, by quite well, I mean give and take 20%. So it's of course not perfect, but it roughly correlates with a CT value on the real-time PCR of about 30. And that happens to also be the CT value, which is often used to indicate infectiousness or not. And for real-time PCR, the CT values, they work sort of backwards. So the lower, the higher the viral load. So a viral load that would give rise to a CT value of below 30 is probably high enough to be infectious and is likely to be picked up by rapid antigen test. Samples with a higher CT value are unlikely to be infectious but also will not be picked up by the rapid antigen test. I have to qualify this though, that even though it is used in good publications and journals, one has to clearly say there is no international standard. There are clear differences in between different assays that labs use. So even comparing our own CT values across different testing platforms and combinations of extraction and amplification systems is not, is actually, only to be done with great care. So it's not exact, and we do not have an internationally accepted quantification standard. So it's a very rough measure. Nevertheless, it proves to be quite useful. The sad thing, though, is that in our own little series of children that we've tested, both by PCR and by rapid antigen test, the rapid antigen test missed all but one case. And the CT values were usually above 30. So for children, we have actually abandoned that. We would rather go for PCR straight away. And that means in urgent cases, children are the clientele for whom we will try to reserve the gene expert cartridges that we get. There is a lot of information on rapid antigen tests out there, so their performance is quite well known. And in fact, for many adult patients, I have become quite a fan of these tests. And then, of course, you will also have family members that they need to be tested. I still think they may, in the context of very limited laboratory capacity, they make a very good additional marker. What we do in the Western Cape, we retest all negatives by antigen test. So we would not normally issue the patient with a result. If it's negative, if it's positive, it's likely to be true positive. In a series of almost 1,000 cases, only one was a false positive by antigen test that could not be confirmed by PCR, but up to a third of negative antigen tests can still be positive by PCR. Again, it will depend on the use. If you are investigating a person with acute COVID, chances are that you will find them positive at hospitalization. That is later on in the course of illness. There will be people who are now getting really sick with COVID and will already be antigen test negative because the viral load is slow enough. So it depends on the circumstances and the use case, but they can help. And of course, they're attractive because they're very fast. Now, what about COVID in children? Our experience is very limited. This is data from the US, which I took here from Clinical Options. And this led people to say, well, it's not a problem for children. Initially thinking that, like with influenza, kids is, where things happen and where that are risk group in their own right, but also transmit to others. That was sort of, it's the pendulum swung the other way, and people, there are people who sort of disregard children as not being important. Early studies that are by now 8 or 9 months old showed already that there is no significant difference in terms of viral loads between children and adults when it comes to SARS-CoV-2 infection. And that means that children are, biologically speaking, there is of course behavioral factors, but biologically speaking, there is no reason why children should not be as infectious as adults can be. This is the CDC case definition for MST. I'm not going into this. The important thing from the diagnostic perspective is that you will miss cases if only testing by PCR. I would strongly advise against using antigen test for making a diagnosis based on its much lower sensitivity, which is clearly not good enough in this context, particularly as we are now talking of people who are later on in their course of illness after becoming infected, whose viral loads will have, be low enough to not be detectable by antigen test. The important thing is that irrespective of RT-PCR, these cases should also be investigated by antibody testing by serology. And that is also what both CDC and the IDSA also recommend. I would not condone the antigen testing recommendations. In my opinion, it should be a question of PCR, nucleic acid testing, supplemented by antibody serology. They add, and I think that is important to keep in mind, even though it's for us, it's probably wishful thinking, but one needs to do serology before administering something that would interfere with the serology. So these monoclonal antibodies will probably not interfere with our usual antibody test that detect antibodies against the nucleoprotein of the virus, which is not the one that is the primary target for the immune response, and therefore does not correlate with immunity, which is what the monoclonals would do. But of course, if giving intravenous immunoglobulin from humans, that would also contain those antibodies. So one needs to obtain a sample prior to administering these. And I think that is a strong recommendation that most people would subscribe to. But of course, the database is small, so it's a smallish number of cases. It's really an expert opinion. I would like to highlight and following on from Keith's presentation of the variant, and of course, and also of the question of the seroprevalence and in how far it would be protective against future waves. What we are encountering more and more are cases of patients who had COVID previously and now test positive again. And I would like to just go through this because it's a common phenomenon and it needs clinical and epidemiological decisions. So the question, could it be the same? Is it just the lingering infection? That is unlikely unless the patient is profoundly immunocompromised when there is active infection that can persist for several weeks. Or is it reinfection? Is it a new infection with presumably a different viral variant or subvariant? So something we can call apart if we do sequencing. Or importantly, is it just residual shedding of viral RNA? And that is actually common and may persist for many weeks after the first infection. And of course, the question is, how do we know that this is not a new infection and the patient isn't infectious again? So it has enormous practical implications. And the difficulty is that timelines, the clinical severity of the previous infection, the types of specimens and the tests done all vary between the cases that have been described. So it's not easy. Here in the Western Cape, we have a sort of an informal working group with colleagues from the Department of Health and the two labs, two public sector labs, And we look at these cases individually, and we know that this prolonged shedding of viral RNA is not uncommon. It does not reflect infectious virus. It has clinically, as far as we can tell, no meaning. And of course, it means that with very low viral loads, results may fluctuate between positive and negatives. You can be just positive enough to just come up on a PCR, very low positive, and the next time the patient is sampled, it's still very low, but now the PCR, because the specimen quality is not as pristine, doesn't pick it up, and the next time it picks it up again. So one has to look at the results and of course at the clinical picture, and this is what we do with these cases. So we start with a careful review of the available clinical, epidemiological, and laboratory information about illness, the indication for retesting. For example, was the patient screened, or had a patient been exposed again? That is common in healthcare workers. And then we look at the CT values. And we are able in that case to actually, in a majority of cases we've looked at, we are able to say this is residual shedding and it does not have any clinical relevance, which is good for the patient concerned. And in some cases, however, we cannot, on the basis of this, decide whether this could be reinfection. So both results are strong positive. There is usually a time difference between the first and the subsequent sample of, 30 days would be cutting it very fine, more likely 45 days in very rare cases. Usually it's more than 3 months, but there are published cases where it was shorter. And then the challenge starts, because now we need to try and obtain all samples that are still available in storage in the labs concerned. And that is a big issue. And this is where many of these investigations end. And I think one has to keep that in mind when saying that reinfections are so rare. So people might argue that, with these, whatever, dozens of millions of infections worldwide, and then there's just whatever 30 or 40 that's been published as reinfections, it obviously seems to be an exception. Well, we can't really tell, because we are, in most cases, we won't find them. Firstly, because somebody would not have been tested during the first or the second episode. So, I mean, obviously it depends on being tested, or then it is not picked up. And we also have that issue. It happens in different laboratories. So unless one puts it all together, one won't find it. Again, the Western CAPS system is very helpful here. And then in order to prove reinfection, one would have to have access to both samples. And this is where the majority fall through, unfortunately. So we retest and then we sequence the virus from both samples. And if it is reinfection, we would see some variation in the viral genome between the two sequences. It doesn't mean it needs to be a new variant, but there are differences. So RNA viruses luckily are mutation happy enough to not remain unchanged between two episodes a few months apart. And then to finish it off, we also go back and confirm that both samples were in fact obtained from the same patient, because that could also have gone wrong. And this is also work which has been supported by this network. And I think that is something, with all the bad news that the variant virus means for us, I think this is something to be proud of in South Africa, that there has been, from the early days, that was started back in April or May last year, there has been this consortium, this network of laboratories, all adjacent or affiliated with NHLS labs, that have been doing sequencing. And that has yielded some very good insights, and the latest of which is now, of course, the emergence of the new variant. And in fact, the UK, they, when you read the timeline, it looks like they were earlier than us, but in fact, they only realized they had a problem in the form of their own variant after they had been alerted by our sort of unofficial first data. And the last country to come to the variant party is, of course, Brazil. And if you hear reports from elsewhere, it is actually amazing that most of the industrialized countries that could afford it do not have something similar in place. So there will, of course, be sequencing of samples in individual places, but there isn't this nationwide coordinated effort. And it is only through that it was possible to look at these samples and then monitor their spread from the Eastern Cape, from PE, into the adjacent parts of the coastal regions, up to KZN and across to the Garden Route, and then onwards to Cape Town, and of course by now into the country as well. So that is something which any one of these centers would not have been able to recognize. You need to really put all the data together, and then obviously also apply very sophisticated molecular epidemiological tools. And I think that's something that, seeing that this is ultimately, of course, a very bitter message, it's something to be proud of. And this was, able to show us that, and of course, this is still a small number of samples here, but it's just absolutely stark how it displaced the other previously circulating main variants. So this is very much similar to what's been observed in the UK, and which may have taken place in other countries as well, only that they might not have realized it until now that everybody is scrambling to also get some genomic surveillance system in place. The good news is that, as Keith already mentioned, that I removed the slide where I had summarized this. The good news is that yes, it does seem to be more contagious, but it doesn't seem to have relevance in terms of disease severity or the age groups affected. The big question is, of course, the immune response, and that is worrying. So we are looking at cases of reinfection, and in fact we have, and that is in preparation, we have identified 2 reinfections due to the variant virus of people who had previously been infected, not with one of the previous variants. But we also have seen that, and looking at you need to take into account that, of course, the infection force was much higher here during our second wave due to the enormous numbers. So the modeling colleagues from Satsima have looked at the whole country's positive results and tried to identify reinfections among them. And of course, I fully admit this is clearly not perfect, and there may be not real reinfections lurking among them, but at least that would be consistent throughout. And they have not identified an excess of reinfections during the second wave compared to what one would expect based on the total number of infections. In other words, and that I think complements very nicely the observations of Khayelitsha as an area with a high seroprevalence that was now relatively spared during the second wave, that there seems to be no epidemiological evidence that immunity resulting or partial immunity resulting from previous infection with one of the older variants would not be at least partially protective in many cases against the new variant. So when the take-home message is, this is my last slide, when talking about testing, there is a difference between screening, that is somebody who comes for admission for a different reason or for healthcare and is tested to exclude SARS CoV-2 infection, and diagnosing a case. For diagnosing in children, if MIS-C is a possibility, clearly it should be PCR combined with antibody testing. For screening, in our opinion, antigen testing, rapid antigen testing cannot be recommended, so it will have to be PCR based, and there the insufficient sensitivity is a problem, at least in our own very small number evaluation in Tygerberg. We not infrequently are asked, so when can the patient come out of isolation, out of the COVID ward and go to the normal ward again? A patient that was picked up by screening, so not as a COVID patient. And in some of these cases, the CT values are quite high, so they're in the upper 30s. And I would be quite confident to say that, seeing that there was no COVID-19 compatible illness, we don't know the timeline in this case. So what we do is we use 10 days of isolation from the date of the first positive diagnostic test to calculate the period during which the patient is potentially infectious. And I'm sure that in quite some of these cases, we are thereby overdoing it. So we're keeping them isolated for longer than is necessary. The problem is that linking CT values to the ability to isolate infectious virus, which we can, but which few labs can, and of course we can't do this at scale, is not an exact science. So I think in individual cases one can come to a decision that and a clinical management decision that takes into account CT values, but I think one needs to review it. And in discussing whether, for example, CT values should be part of routine PCR test reports, we agreed that it's probably not a good idea because it may be misinterpreted. So it remains an individual decision that should be taken with the clinicians and possibly lab people involved in this. To investigate cases of possible mislead, it needs to look for the virus itself by PCR, and for specific IgG antibodies. Do not really waste time and resources on anything but IgG antibodies. The significance of IgM and in some assays also IgA antibodies is very low. So it's nothing that cannot be happily replaced by a combination of PCR and IgG antibody testing. Reinfections do occur, and that's not a new thing, not linked to the new variant. That clearly indicates that natural immunity is not reliable. Just how unreliable it is and the timeline of that, we simply do not know very well. When you see these studies, and there are many of them, keep in mind that they tend to vary in the type of patient population investigated and the type of tests done, the type of samples. So it's very difficult to glean any reliable data from these. And then in summary, our new variant 501YV2, as is the proper name, we shouldn't call them after places, but I still think South African variant sounds it's easier to pronounce than 501Y.B2. It's likely more transmissible as its UK counterpart, and probably also the Brazilian one from Manaus. So far, there is no evidence for any difference in terms of clinical presentation, age, on different ages and so on. But there are worrying early reports of possibly immune evasion. So far, this is based on in vitro studies, and that is alarming. But I personally would not throw in the towel. I still think that the vaccines, and I hope we get them soonish, the vaccines elicit such a good immunity, mostly, and a broad immunity, that I would not be too worried about maybe a slight reduction in the efficacy. However, that said, if you slide down from 90% to, let's say, 75 or 70%, it basically means in order to reach herd immunity, you would have to vaccinate more people. So it is something that needs to be watched, and it is being watched. This morning alone, there were 2 calls of various groups and subgroups of the national variant consortium. Yesterday, we had one. So it is something that people are looking at very actively. I'm sure that week after week we will learn more about it. But in the meantime, I think there's no reason to change track. I think it's non-medical interventions, and then heading for vaccine as much as we can and as soon as we can. That is it from my side, and I would like to thank you very much for listening. Thank you.
Wolfgang, thank you very much for that, and especially for putting that talk together at such late notice and after hours. We have had a number of questions. I'm not sure if you are now able to see the chat, and I'm not sure if we will have time to go through all of the queries. I'm going to pick up a couple of themes and potentially leave some that weren't necessarily related to this topic. The first is a general question just around how the labs are doing, the frontline lab people, in terms of their overall testing capacity, considering other tests, like, for example, HIV testing? What's your sense from Tygerberg or from speaking to national colleagues?
There is, to my knowledge, not a problem. I mean, we had to redeploy staff across different sections of the lab, but actually that benefited in a way from the reduction in other services. So test requests were lower. To my knowledge, there has not been any negative effect. So I think these things work comfortably alongside one another, helped by the fact that it often uses different systems.
Got a couple of questions related to the antigen test, which maybe you can just clarify then for people how you're using the antigen testing in adults versus children based on recent experience. The specific questions are, for example, could the antigen test then replace the PCR test as a more affordable option potentially with a PCR follow-up if the test was negative? And should we be taking 2 swabs or only 1?
Yeah, so I mean the antigen test that we have, which is the Abbott Pan Bio, is and we had to try this out. You can't, the manufacturer won't help here. We are happy to just have 1 sample, and it turned out that a dry swab is ideal, which would then first be eluted in a special buffer that the antigen test actually needs. It cannot be replaced with anything else, which is also why it's better to send it dry and not in any medium. And then subsequently we add buffer again, and even though there is some dilution effect, it doesn't seem to be significant, and then we test them by PCR, and that is our routine procedure for negative antigen test results. So it's basically 1 sample per patient, and it works quite nicely. I'm sorry, I just pick up the CT. That is the cycle threshold. It's a technical term. Forgive me for using that. It's a technical term that basically says at what point does the PCR become positive, and this is also why it works the other way around. So the earlier it is, the higher the viral load in the specimen. So the high positive specimens would have a low CT value. They come up early on. And the specimens that have a low viral load would take longer to become positive, so they have a higher CT value. Sorry for not mentioning that. And the antibody testing is available in the NHLS. We actually test very few routine samples, and they're mainly pediatric cases. They are, however, being used for these epidemiological studies.
And perhaps your final thoughts, just some wisdom. You've explained the complexity around interpreting CT values, the decision to not report them, but rather just to report a positive or a negative on the NHLS. And yet, as we've discovered, potentially we are then isolating children unnecessarily who are probably not infectious. So there's a question around, if you do have a positive a test on day 10, how long do you wait to repeat the test? Do you need a negative test? So maybe just some wisdom around when to call your friendly virologist.
Yeah, my first recommendation would be not to retest. So, to avoid this complication, and I know it just doesn't work like this in practice, but, if somebody's been tested positive and then had the 10 days of isolation, you can happily, I'm not talking hug the person because we stopped hugging people anyway, but, you can let them out of isolation without further testing. And I know this is exactly also how these possible reinfection cases that we then need to review, how they come about. They are being tested because they are undergoing a procedure or want to travel or something like that, and then they are being screened and they come up positive. And this is why we see all those tail ends of low viral loads. In that case, I would recommend contacting the laboratory and discussing it. But of course, it depends on the institutional rules and regulations and probably the person in charge, whether they would see that, the virtue of, this patient no longer being infectious, or whether they would insist on following the letter of their, of their rules. And I do understand and sympathize with the problems. This is why I think it needs to be an individual decision. But it can be clearly said that except for people with profound immunodeficiency, there is no infectious virus being shed beyond 10 days after onset of illness. Or if there is no clinical illness, 10 days after the first test result.
Thank you very much again, Wolfgang, for your time and expertise.
Thank you.
Apologies for those questions that we haven't covered, but it's time to ask the question to school or not to school. So I'll hand back over to Prof. McCullough.